Hello, everyone. Thank you so much for your patience. We just had a few technical difficulties, so we'll just let you all come in.
Will you make it full screen?
Yep.
Thank you.
There we go.
Yep. That looks good.
Perfect. Okay. Whoops. My computer's just moving stuff now. Okay, so I see everybody's coming in. Great. Welcome, everyone. Thank you so much for your patience. We're sorry we had a few technical issues, but we're here. So thank you so much for joining today's webinar. My name is Kimberly Brunel, and I'm a patient support liaison with AMAC. If you don't know who we are, AMAC is a leading funder of research into bone marrow failure diseases. Our organization supports patients and caregivers from across the country who are living with aplastic anemia, myelodysplastic syndrome, and PNH. I am so pleased to be joined today by Dr. Rena Buckstein. Dr. Buckstein is a clinician investigator at the Odette Cancer Center at Sunnybrook, who specializes in malignant hematology. She's also an associate professor in the Department of Medicine at University of Toronto and enjoys teaching and mentoring undergraduate and graduate students. So at this time, all the lines are muted. And so if you have a question, just feel free to type it into the chat box and we'll cover it by the end of the session. The webinar today is recorded and will be available later on our website. And so without further ado, I'll pass it over to Dr. Buckstein.
Hello, everybody out there in the ether. Nice to meet you. I'm happy to speak to you about myelodysplastic syndrome as it relates to you and hopefully educate you about where we're going. Next slide, please. Next slide. So I'm going to start with a case, then talk about how we diagnose and prognosticate the disease, review the current therapeutic algorithm for both lower risk and higher risk disease, discuss some of the newer approved agents in myelodysplastic syndrome, and highlight some of the exciting new clinical trials, some of which are ongoing and potentially eligible to you. Next slide. So let's start with a case. He's a 71-year-old male patient. He's a retired teacher, past history of hypertension, type 2 diabetes, and some osteoarthritis of his back. The family history is unremarkable for any hematologic cancers or cancers in general. He's married, children are grown, he even has grandchildren. He's physically active. He walks an hour every day for exercise. And he is a past smoker, but not in the last 30 years. And he drinks alcohol socially. Next slide. So he's been complaining to his GP about increasing fatigue over the last 2 months. He doesn't have the same stamina. He can't walk as fast. Sometimes even when he walks to the top of a long flight of stairs, he's a bit short of breath, which is unusual for him. But he doesn't endorse any other significant localizing symptoms, just this fatigue. His physical examination is normal. And the GP orders some blood work and finds that he has anemia with a hemoglobin of 105, normal for a man being 135 to 175. His white blood cell count is a little bit low at 3.5, normal being about actually 4 to 10. His neutrophils are a little reduced at 1.5. They should be about 2 to 8. His platelets are 130, which again are just a little bit below the normal reference range. So he's referred to me as a hematologist who works up bone marrow failure, and I perform a bone marrow aspirate and biopsy. And the bone marrow makes the diagnosis of myelodysplastic syndrome, and the classification according to the World Health Organization is refractory cytopenia with multilineage dysplasia and ring sideroblasts, which we'll talk about. And his blasts, his leukemic blasts are not increased at 3%, well, minimally increased at 3%. And you do chromosome analysis, what are called cytogenetics, where they culture cells and they look at the metaphases of the cells in cycle, and you find that he has normal complement of chromosomes for what we call 46XY, 46 chromosomes and an X and a Y chromosome. Next slide. So what is this diagnosis of MDS? What's his prognosis? Is it curable? And what are my patient's treatment options? Next slide. So, every single review article on MDS always uses the word heterogeneous, because that's exactly what it is. It's very heterogeneous. It varies from patient to patient, from country to country, but in general, it is a form of blood cancer that affects the myeloid stem cell. And we call it clonal because there's a malignant clone that's responsible for this disease. The incidence is fairly low, all comers. It's about 4 cases per 100,000, but it rises dramatically with age. You'll see on the next slide. And roughly, there are about 8,700 new cases diagnosed each year in Canada. In general, it's more common in men than women. It may arise after patients have previously had chemotherapy or radiation. We call that secondary MDS, or there are some occupational exposures that associated. Farmers, people who work with benzene, petroleum products, and so forth, formaldehyde. How do patients present? They present typically either with just asymptomatic low blood counts or symptomatic low blood counts. They may present with infections and you find they have a very low white count. They may present with bleeding because their platelets are low or not functioning. Only about 1/4 to 1/3 of patients will develop acute myeloid leukemia, which is sort of the dreaded and most devastating end of this disease. However, even without developing AML, this disease has serious implications for health and survival. And it's been likened to sort of stage 3 lung cancer in terms of how long people can live with this disease, mainly because of complications such as bleeding and infection. Well, actually, I would say infection, cardiovascular disease, and bleeding only in about 5 to 7% of cases. Now, the only potential cure for this disease is a bone marrow transplant, which we'll also talk about. Next slide. So what is bone marrow? What's normal bone marrow? So in adults, most of our bone marrow resides in our pelvis, some of our long bones in our vertebrae. And bone marrow is where all the elements of our blood, both myeloid and lymphoid, originate. And so you start off with this what we call a stem cell. That's very immature looking under the microscope. It looks like, like it could be any cell. And then it branches off into either being slated to become a lymphocyte, so a lymphoid progenitor cell, or a myeloid progenitor cell. And the myeloid, and MDS is a disease generally of the myeloid progenitor cell. And the myeloid progenitor cell undergoes a bunch of branchings and maturations to culminate or end up with the production of the elements of your blood. Your what we call granulocytes, which are your neutrophils, your basophils, your eosinophils, your macrophages or monocytes, and then also the element of your blood that helps you stop bleeding, called platelets, and the elements of your blood that carry oxygen, called your red blood cells. So MDS is a disease of the myeloid progenitor cell, which means that the progeny or the offspring of this myeloid progenitor cell are going to be affected. So whatever damage happens to that myeloid progenitor cell will be reflected downstream in the cells that end up making the elements of your blood. Next slide. How do patients present? Well, they can present like our patient, endorsing fatigue or reduced exercise tolerance, breathlessness, easy bruising or bleeding. Some patients present with weight loss that's involuntary, or bone pain. This common complaint is just, I don't have the stamina I used to have. And some patients, the diagnosis is made asymptomatically. The patient was just going for regular blood tests with their family doctor, and the family doctor noted that the blood counts had reduced compared to previous, and then they get investigated. Next slide. So this just shows you how this disease, which is overall 4 cases per 100,000, goes up dramatically with age. And above the age of 70, it's about 21 cases per 100,000, and above the age of 80, it's 36 cases per 100,000. Next slide. We don't, most of the time, we don't know what causes MDS. We think it's basically it's age. If you live long enough, damage to your stem cells can occur, and it's pretty common, in fact. But there are, again, some mutagens that you may have been exposed to in your lifetime that increases that risk of genetic damage that are listed on the slide. And there's certain classes of chemotherapy drugs we pay attention to. Smoking is a risk factor, obesity is a risk factor. And we also know that people who have a history of autoimmune diseases like lupus, rheumatoid arthritis, inflammatory bowel disease, we see higher rates of MDS in these patients as well. And in about 10 to 20% of the cases, there's a hereditary gene that they've inherited that predisposes them to develop this disease as well. Next slide. So how do you make the diagnosis? Well, you can suspect it from the blood, but you really can only make the diagnosis when you do a bone marrow aspirate or biopsy, which you all know too well, unfortunately. We classify it according to the World Health Organization classification of myelodysplastic syndrome, but basically it's about 8 different subtypes. But it classifies patients according to how many of the blood lineages under the microscope look abnormal, or as we say, dysplastic. Is it one lineage or more than one lineage? So that determines if you're unilineage or multilineage dysplasia. We also look at the percentage of immature leukemia blasts. Normal is actually less than 2%, but well, actually, normal is less than 5%, although if you even have more than 2% blasts, it actually factors into prognosis. And 20% defines leukemia. We also look at the chromosomes. How many chromosome abnormalities are there? What kind of chromosome abnormalities? And is one in particular called chromosome deletion 5q present, because there's a unique subtype of MDS called deletion 5q MDS. And then we'll do a special Prussian blue stain and look to see, you can see in the middle panel, what looks like little blue rings around the nucleus in a red cell, the immature red cell. And if more than 15% of these red cell precursors, we call them, harbor this ions around them, making a ring, we call that ring sideroblasts. And that's really relevant because of the new drug that's currently on the market called pattercept. Next slide. How do we prognosticate? We have a number of prognostic scoring systems, and this is by no means all of them that are out there. But in North America, the most commonly used ones are the IPSS and the IPSS revised. The IPSS molecular is coming and stresses the importance of not only doing cytogenetic testing, but also genetic or molecular testing in the bone marrow at diagnosis. And what do we use these prognostic scoring systems for? Well, they provide your clinician an estimation of roughly how long you might live, on a population level, and also the probability of developing AML, acute myeloid leukemia. And we roughly kind of want to know, are somebody considered lower risk, meaning they're going to live a long time or relatively a long time and have a low probability of developing AML, or are they higher risk because our treatment algorithms are based on risk score. Next slide. So here's the elements of the IPSS-R. It basically is a weighted scoring system that provides weighting according to your cytogenetics, and they're defined here. So you have very good, good, intermediate, and very poor. Our patient would be considered good with a score of 1 because he's normal. He doesn't have any abnormalities. It looks at the blast percentage, less than 2%, greater than 2 to less than 5%, and then 5 to 10 or greater than 10. So our patient, again, would get a score of 1 because his blasts were 3%. And then it looks at the blood counts. Now, our patient had reasonably preserved blood counts. Even though they were reduced for him, they were still quite good. And so he wouldn't get any points. He'd get scores of 0 for his blood counts. So his total score is a risk score of 2, which classifies him as low risk, with a median survival of 5.3 years. And the time it takes for a quarter of the patients with this risk score to develop AML is 11 years. So a relatively low risk of developing AML in the foreseeable future. Next slide. Now, we also know that genetic mutations are basically seen in almost all patients with MDS. Probably 80 to 90% will harbor genetic mutations in various different genes whose function is involved in different pathways of cell function, such as whether or not it's going to be involved in splicing your RNA, or abnormally methylating your DNA, or signaling pathways, or tumor suppressor genes, and so forth. And scientists have actually worked out from like early MDS to late MDS where these mutations occur, such that sort of having mutations in these genes tends not to be such a bad prognosis because it's early MDS. But if you start harboring mutations in some of these genes, it tends to bode for more imminent AML. Next slide. The number of mutations that an MDS patient that we find in MDS bone marrow is also of prognostic importance. The more mutations we find, the worse their survival. These are what are called Kaplan-Meier survival curves. This is for leukemia-free survival, and this is for overall survival. The more mutations you have, the worse things go, because it means the disease is more genetically advanced and more aggressive. We know on all comers with MDS, they will harbor about a median of 3 mutations. And not surprisingly, the more blasts somebody has in their bone marrow, the more mutations they harbor. Whereas patients who are sort of earlier forms of MDS, like our person has, ring sideroblast subtype, he has a number of mutations that's probably just over 2. Next slide. Now, recently presented, and it'll be presented at our annual meeting this year, is the composite of a big effort, international effort, using a database of more than 4,000 patients' data with clinical information about how they did, as well as their genetics and chromosomes and blood counts and so forth. And we have now coming what's called the IPSS-M that will be putting weighting on the presence or absence of mutations in the genes that are listed on this slide, as well as how many mutations you have. So now, instead of 5 risk categories, we're going to actually have 6 risk categories. Next slide. That have better risk stratifies the probability of developing leukemia and how long someone's going to live. So somebody in the very, very low risk group is expected to live about 10 years, whereas somebody in the very high risk group is expected to live only about 1 year. And this stresses the importance of having genetic sequencing available at the time of diagnosis in MDS bone marrows. The problem is, at least in Ontario, that the Ministry of Health does not yet fund genetic testing or sequencing in our MDS patients, and we've been lobbying the government to incorporate that. We are actually part of, I'm part of a Cancer Care Ontario committee that is advocating for the baseline standards of MDS investigation, that it includes genetic sequencing. So we hope in the next year that this will become part of standard of, funded standard of care. Next slide. Now, at our meeting last year, the Spanish registry, looking at a huge number of patients, actually demonstrated, they said, well, let's identify using the IPSS-R, the threshold score that best discriminates prognosis. And they used a definition of living more than 30 months as being low risk and living less than 30 months as high risk. And what they found is that the threshold score of 3.5 was the best score for distinguishing survival. So that if you have a score of less than or equal to 3.5, median survival is 75 months versus 15.4 months less than that. And so we are using that now in the clinic and in clinical trial design to decide on who is lower risk and higher risk until the IPSS-M becomes the standard of care. Next slide. So it's important to mention that it's not just disease factors that play a role in how long someone's going to live. You know, the median age of diagnosis is 76. So many patients above this age have other health problems. They may be disabled by bad arthritis. They may have a lot of other health problems like cardiac disease or poorly treated diabetes and complications, such that they may have disabilities, or they may be frail. We know that fatigue, just how much a patient complains of fatigue, will impact how long they live, as well as what other health problems they have. And numerous studies have been done, including research through the National MDS Registry in Canada, that have shown that if you incorporate what I call patient-related factors into our prognostic scoring system, that we can further refine the prognosis by 20 to 30%. What does that mean? It means that, for example, if you have a high-risk score, but you're in great shape, you're probably going to live longer than what the prognostic score tells you that you're going to live, or estimates is your life expectancy. Next slide. So what are the goals of treatment? And you know, there's definitely a huge overlap between what we call lower risk disease. Let's say, for the purpose of this talk, an IPSS-R score of less than or equal to 3.5. Well, we want to improve bone marrow function. We want to decrease or eliminate transfusions. We want to improve quality of life, because we know this disease definitely has an impact on quality of life. And ideally, we also want to improve survival, because we know that even if you don't develop leukemia, the complications of your low blood counts may shorten your survival. And for higher risk disease, there's a greater urgency of, number one, avoiding the development of leukemia. So we want to delay that time, or ideally prevent it from happening. We want to improve survival. We also want to improve quality of life. And we also want to decrease or eliminate transfusions, because those become even more prevalent as the risk score goes up. Next slide. So here's the algorithm that we have today for managing anemia, which is the most prevalent low blood count that we face in managing MDS. Essentially, the first thing we'll do is we'll measure what's called an erythropoietin level. An erythropoietin level is the hormone that our kidneys make and our liver makes, that regulates how much your bone marrow makes red blood cells. So if you're, and we know that people whose erythropoietin level is over 200 are unlikely to benefit from receiving an erythropoietin stimulating agent, something like Eprex or darbepoetin, Aranesp. So the first thing we'll do is we'll look at that. We also know that patients who are receiving more than 2 units of blood every month are also less likely to respond to EPO. So let's say you don't have a high EPO level and you're receiving less than 2 units per month. Our first go-to drug will be erythropoietin. Now, if that doesn't work, and you also happen to be in the 5 to 10% that harbor that chromosome abnormality called deletion 5q. I'm sorry, I'm not controlling the slide, so I can't use my cursor. Under ESA in orange, there's something called deletion 5q. If you're in the 5 to 10% that has deletion 5q, there is a targeted agent we can prescribe called lenalidomide. But 90% don't have deletion 5q, in which case our options are to try to get lenalidomide, although it's not funded by the ministry, and sometimes reintroduce erythropoietin, because there may be some evidence of synergy between those two. Another option, if you're transfusion dependent, is to use a hypomethylating agent such as azacitidine, or now we're also going to talk about this new oral hypomethylating agent called INQOVI. Now, if you have ring sideroblasts, another option is available to you if you've not responded to erythropoietin, or you've responded and now you're no longer responding and now requiring transfusions, would be to use a drug called pattercept. And we're going to talk about that. In the patients, however, who have who are not good candidates to start with an erythropoietin stimulating agent, if you're younger, sometimes we benefit from using an immunosuppressive therapy, but we don't have that many patients below the age of 60 diagnosed with this disease. So the majority of the patients who are above the age of 60 who aren't good candidates for erythropoietin-stimulating agents, we would then follow on the left panel the non-del5q pathway. Next slide. Our algorithm for treating higher risk disease is much simpler. Really, we only have available to us hypomethylating agents. And then we have to decide, is the patient a transplant candidate, a bone marrow transplant candidate, yes or no? And, basically based on their fitness, based on their age, and so forth. Generally, it's very uncommon above the age of 70, but some patients up to the age of 75 who are in the greatest of shape will be considered a candidate for an allogeneic stem cell transplant. Then you have to find a donor. And if there is a donor, then the recommendation is to go on and have a bone marrow transplant. But if there is no donor, then we use a hypomethylating agent. And if that doesn't work, we try to enroll patients on clinical trials. Now, having said that, at any decision node of both algorithms, a clinical trial is always a great idea. Next slide. So I mentioned luspatercept for patients who have ring sideroblasts. So we know that one of the mechanisms of the ineffective production of red blood cells in patients with MDS is this overexpression of signaling molecules inside the cell called SMAD2 and 3. You can see that in the far left cartoon. And what causes signaling through the SMAD2/3 pathway is the binding to receptors that sit on these red cell membranes, these red cell precursor membranes called activin receptors. And the proteins that bind into that little space are called transforming growth factor ligands. And so basically, if you can mop up these ligands and prevent them from fitting into that key, it's like a key inside of a lock. If you mop them up and prevent them from doing so, you effectively can decrease SMAD2/3 signaling, which puts a block on the maturation of red blood cells. So we think that erythropoietin stimulating agents like EPREX and darbepoetin work early at the very immature stages of red cell production, but luspatercept works in the distal part of red cell production, where you have these brakes put on because of SMAD signaling. But by removing the brakes with this drug, this recombinant fusion protein called luspatercept, you effectively can release the brake, allow the red cells to fully mature into red cells and get released into the blood. Next slide. So this was a New England Journal Medicine paper a year or two ago. That is why we now have the drug luspatercept. Next slide. This is based on the study called the medalist study, and patients who are adults with MDS who have ring sideroblasts, who classified according to the risk score as very low, lower, intermediate, who had either not responded to erythropoietin stimulating agents or didn't tolerate them, or were ineligible to receive them because their endogenous EPO levels were too high and were requiring red cell transfusions, were randomized. It was 229 patients in a 2-to-1 fashion, where patients received either luspatercept in a dose escalating fashion or placebo. So 153 got luspatercept and 76 got placebo. And the primary endpoint of the trial was the achievement of red blood cell transfusion independence for at least 8 weeks in the first 6 months. And then there were many other endpoints: how long you remained transfusion independent, did you have a reduction in your transfusions, even if you didn't completely eliminate transfusions, how did some people stay transfusion independent for 12 weeks or longer, and so forth. And patients basically could stay on study until you determined that they weren't benefiting or there was progressive disease. Next slide. So in terms of the primary endpoint, in the first 24 weeks, 38% of the patients who got luspatercept achieved red blood cell transfusion independence for 8 weeks or more, compared to 13.2% in the placebo arm. Now, if you followed them for the duration of the study, how long they remained on study, because there were some late responders, 48% achieved red blood cell transfusion independence at any time who got luspatercept versus 16% who got placebo. Now, if you broadened your inclusion to include a reduction in transfusion need, then about 53% of patients either had a reduction or achieved a duration of transfusion independence of 8 weeks or more, compared to 12% with placebo. Next slide. Now, that means that some of the patients sort of would go, let's say 6 weeks and not need a transfusion and then have a unit of blood. And then they might go 8 weeks and get a transfusion. Then they might go 12 weeks and then get a transfusion. So it didn't completely eliminate their transfusions. But if you added up all the weeks that they remained off transfusions versus receiving transfusions in the was 80 weeks for luspatercept and 21 weeks for placebo. So definitely an improvement. And that translated over 48 weeks, so almost a year, into 12 fewer units of blood and 6 fewer transfusion visits, which is clinically meaningful for patients, at least in my opinion, who are spending a lot of time at the hospital getting their blood. Next slide. We give it under the skin as a subcutaneous injection every 3 weeks. You start at a low dose of 1 milligram per kilo, and every 6 weeks you can dose escalate to as high as 1.75 milligrams per kilo. And the majority of patients who were on the study who were responders either received 1.33 or 1.75 milligrams per kilo. Next slide. So what are the side effects? It's not too dissimilar to erythropoietin stimulating agents, but there is a signal, at least early on at the beginning when you start getting the injections, is there's a little bit more of fatigue or asthenia that some of the patients complain of, or a dizziness. This is a comparison of all grades. So from grade 1, which is like the most minimal of symptoms, to grade 4, which is the most severe of symptoms. So all grades, there's definitely a bit more fatigue, a bit more diarrhea, a bit more nausea, a bit more dizziness with luspatercept. But if you focus on just the severe toxicities, grade 3 or 4, they're all sort of like 6%, very, very low rates. Next slide. Similarly, a little bit more back pain with the luspatercept, at least at the beginning, and maybe a slight imbalance with like more infections, but the numbers here are so small that they're altering the percentages more dramatically. Next slide. So what are other, so this drug now is available compassionately from BMS, who makes luspatercept. And it has received some favorable review at the Ministry of Health for funding. But there's obviously going to be some negotiations. So I expect this drug will be on our formulary, but for now, it is available. Your hematologist can prescribe it to you. If you happen to have ring sideroblasts and you're red cell transfusion dependent, they can obtain it for you from the compassionate use program. What are other agents that are being evaluated in clinical trials or are even available now to treat transfusion dependence, even in lower risk disease? Next slide. So this is some exciting new research. This IMerge study actually just closed to accrual. We actually put one of the last patients eligible to go on the study when accrual closed at Sunnybrook. Imtelstat is a drug that targets an enzyme called telomerase. Your telomeres are like the plastic doodads at the end of your shoelaces, the ones that maintain the integrity of your chromosomes and prevent them from unraveling. So telomerase is the enzyme that maintains your telomeres. And in cells that are dividing all the time, you need to have pretty active telomerase. And if your telomerase is not working, then that cell is going to, the chromosome is going to unravel and be damaged, and the cell will die, which is a good thing if it's a cancer cell. And so what Imtelstat does is it inhibits one of these enzymes, these telomerase enzymes, and prevents them from doing what they're supposed to do, which is maintain the telomere. And as a result, it has an effective activity at killing these cancer stem cells, or leukemia stem cells, or MDS stem cells. And so in a phase 2 study that has now led to this phase 3 study that has just finished accrual, patients were randomized between placebo or Imtelstat. Very similar patient population to that of the medalist study of the loose pattercept randomized trial, except I would say these patients were even more heavily transfusion dependent, and even less likely to respond to erythropoietin. And what's nice about this drug is they saw a very similar signal where 42% were able to get off of transfusions for at least 8 weeks, and 68% derived benefit as well, with a reduction of transfusions. And the duration of response was very long. If you were lucky enough to be in that responding population, it lasted more than a year, 86 weeks. Whereas with luspatercept, the average duration of response is about 42 weeks. Next slide. So this is not yet available, but we're waiting for the phase 3 results to play out and read out. Another drug that's undergoing testing is a drug called Roxatrex. I don't even know how to pronounce it properly. It's actually used for dialysis patients or anemia patients who have renal failure. But what this drug does is it pretends as if there's low oxygen state in the cell. As a result, it's what we call a HIF-alpha prolyl hydroxylase domain inhibitor. But basically, effectively, what it does is it helps increase the EPO levels in the cell or in the blood, and it also improves the availability of iron that's trapped, and allows red blood cell production to improve. And in their very small study, it's what we call a phase 1/2 study, there seemed to be a signal of activity of about 38% as well. But again, the sample sizes are very small, only 24 patients. And so we'll have to wait and see whether or not it's really a bona fide, great agent when the phase 3 study reads out. Next slide. Now, hypomethylating agents are also options for treating lower risk and higher risk MDS. So patients don't always fully understand what azacitidine or decitabine are. So they fall under a class of chemotherapy drugs that we call hypomethylating agents. By what do I mean that? So if you remember your grade 12 or grade 11 biology.
Your attention, please. Your attention, please.
Sorry.
Code Brown. S Sierra 6 kitchen.
I'm at the hospital and
your attention, please.
There's an
Code
announcement.
Brown. S Sierra 6 kitchen.
Somebody spilled something in the kitchen. So you remember there's 4 bases that make up your DNA, and one of these bases is cytosine. And cytosine is like one of the building blocks of your DNA. It's usually bound to guanine. And if there are methyl groups, these what do we call CH3 groups attached to the cytosine, what it does is it effectively causes the DNA to be excessively coiled and not available to be read. And for DNA, which is the blueprint of your cell that determines what proteins are going to be made, if the DNA is too tightly wound and coiled, the things that read the DNA, what we call transcription factors, can't get in there and copy the DNA, then goes back outside the nucleus, goes to the part of the machinery of the cell called the ribosome to make protein. So it means that your genes are effectively silenced. And what azacitidine and decitabine do is they inhibit the enzyme that allows cytosine to be methylated. They inhibit the enzymes, the DNA methyltransferases. And basically, the end result of that is when the cell goes to divide, is that the DNA is now unmethylated, and the transcription factors can then get in there and read the open chromatin, transcribe the genes, that then translates into the production of proteins that allows the cell to have a normal operations, normal machinery. So we have two hypomethylating agents available, azacitidine and decitabine. Aza is given for 7 days under the skin, and decitabine is given intravenously for 5 days. Now, decitabine, even though it is licensed in Canada, has never been used. It's never been funded in Canada, but until now, and we'll get to that. Next slide. So decitabine that is typically given IV, one of its Achilles heels and reasons for resistance in patients who receive decitabine is that it's excessively metabolized by an enzyme called cytidine deaminase, and it leads to an inactive form of decitabine, and which again, remember, is a DNA methyltransferase inhibitor. So a new drug, an agent called cedazuridine, basically blocks this enzyme that degrades or converts decitabine to an inactive form and allows the decitabine to hang around longer, demethylate the DNA more than it as a result, and effectively accomplish what the intravenous decitabine used to accomplish, because the decitabine, even though it's given orally, will hang around for longer. Next slide. And the study that established that the oral formulation of decitabine is equivalent to IV decitabine is the study called Ascertain. And in this study, patients who were considered candidates for a hypomethylating agent in the United States, they use a lot of IV decitabine. They had to have either intermediate or higher risk MDS or CMML, or what we call low blast AML. They could be enrolled. And effectively, everyone got the drug eventually, but they started off in the first cycle with either one or the other, either the pill form of decitabine or the IV form of the decitabine. In the second cycle, they switched and got the exact opposite. And from cycle 3 on, they all got the oral formulation. And the objective of the study was to prove that the oral formulation is identical to the intravenous formulation based on drug levels as well as activity of the drug. And of course, they were also looking at other important endpoints like how many patients got off of transfusions, how many remissions were seen, how long did responses last, what is survival, and they looked, of course, at safety. Next slide. So these are the characteristics of the patients that were enrolled. It was 133 patients. And I want to point out, and which is why I said this is a good drug even for lower risk MDS patients, is because 53% of the patients enrolled on the study were in fact lower risk, and 36% were higher risk. About 40% were dependent on transfusions, red blood cell transfusions, and there was a predominance of male patients with a median age of 71. Next slide. So first of all, in terms of its primary objective, it established it. It basically showed that using something called the area under the curve, which measures the exposure to the drug in the blood, they found that the IV and the oral formulation of decitabine were equivalent. In addition, in terms of its activity at working to decrease methylation, by inhibiting DNA methyltransferase, they accomplished that as well. The amount, we call that pharmacodynamic. Does it hit its target? And in fact, it showed that the oral formulation and the IV formulation both hit their targets in the same way. Next slide. How about activity? So in hypomethylating agent trials, we don't typically see a lot of complete remissions. Complete response would be normal blood counts or almost normal blood counts, and the blasts in the bone marrow less than 5%. So about 22% of patients achieve that. But 32%, their bone marrows, achieved a remission, meaning less than 5% blasts. And 16.5% achieved both a marrow remission and improvement in their blood counts. And then a further about 7.5% had improvement in their blood counts. So if you add up all these remissions and so forth, or responses, it translates to about a 62% response rate, with very few patients actually progressing while on the drug. Now, how long did it take to achieve remission, complete remission? It was about 4.5 months. These drugs don't work quickly because they rely on the cell dividing for the methyltransferase inhibitor to kick in and do what it's supposed to do. If you achieved a complete remission, it lasted about 14 months. And importantly, a quarter of these patients were able to go on to bone marrow transplant after they received this drug. So it was a good bridge to going to transplant. Also, more than half of the patients achieved either independence of red blood cells or platelets. Next slide. So with the updated follow-up, we know that the overall survival is about 32 months for patients enrolled on the study. So 50% are still alive and well at 32 months. Now, if you restrict your analysis to a third of patients, remember that's a smaller group number of patients, the median survival for higher risk disease is about 15 months, which is what we expect typically with azacitidine as well. Next slide. And there is toxicities associated with these hypomethylating agents, maybe a bit more reduction in blood counts with decitabine than we see with azacitidine, a little bit more suppression of the neutrophil count, the platelet count, and about 13% of patients ended up in hospital with a fever and a low white cell count. So mainly what we call hematologic toxicities, meaning affecting the blood counts, but not a lot of other toxicities. Next slide. So we're always now faced, now that we have INQOVI, which is not yet funded, but again, also favorably reviewed by the regulatory authorities for funding, and it's now probably just under negotiation. But so this drug is going to be available right now. Again, just like pattercept, it's obtainable on a compassionate use program from the company Taiho that manufactures it. The question is, which one should I prescribe then for my patients? This is observational data. We don't have a head-to-head comparison. There's no clinical trials that have compared them head-to-head. So in a randomized trial, in a non-randomized fashion, what we call observational data, it looks from this large Medicare study from the United States that the survivals using azacitidine or decitabine in the dotted line are superimposable. And then if you restrict your analysis to those who have just what we consider higher risk subtypes where they have more than 5% blasts, again, the survival curves look superimposable. But this is observational data. It's not high-level phase 3 data. Next slide. So there are advantages and disadvantages to azacitidine and then to decitabine or Dexy, we call it, that I'm going to highlight to you that will factor into the decision making that you and your physician make. So first of all, we know azacitidine is in a randomized trial compared to conventional care has provided a survival benefit with higher risk disease. It's not too suppressive of the blood count. Certainly some patients, it really bottoms them out, but compared to decitabine, I would say it's a little less tough on the blood counts. It can be used as a bridge to transplant. About 40% of patients will get off of red blood cell transfusions if they're dependent on them. And there's flexibility in dose adjustment because it's given at 75 milligrams per meter squared for 7 days. But in some patients, you find, okay, I should give them a 50 milligrams per meter squared or 5 days instead of 7 days and so forth. So there's a little bit more flexibility. The disadvantage is it's very slow to work. It can take up to 6 cycles to see if it's working or not. It requires you to come 7 days in a row or in a what we call a 5-2-2 schedule. 5 days on, weekend off, Monday, Tuesday, the following week to come to the chemo clinic and get these needles. There are some local skin reactions that can be uncomfortable for some patients. And right now, azacitidine is not funded for lower risk disease. So if you have lower risk disease according to the IPSS-R or IPSS, and you're transfusion dependent and there's no other options for you, you can't get azacitidine. Next slide. So what are advantages of the new oral formulation of decitabine? Well, first of all, oral. It's convenient for you to take it home. It does work quickly to reduce blasts. So if you're wanting to use it as a bridge to transplant, it's probably a good drug to think about. And it achieves red blood cell transfusion independence in about 50% of patients. Actually, that's both red cell and platelet transfusion independence. And we now have it available for lower risk disease. Some of the disadvantages are, though, is that we don't have a randomized trial with Dexy given in this current formulation or IV decitabine given in the current dosing against conventional care to show that it provides a survival benefit. We don't know if it's equivalent to AZA. They do have slightly different mechanisms of action. In addition to their inhibition of DNA methyltransferases, they also work to damage the cancer cells in other ways, and they're not exactly equivalent. Decitabine, I mentioned, is a bit more suppressive of the blood counts at the beginning, and you've got less flexibility in dose adjustment because the pill is formed. You can't reduce the pill or split it. So all you can really do is reduce the number of days that you receive it, which is what we sometimes do. And it's not yet funded, but I expect it will be very shortly. Next slide. There are a number of clinical trials ongoing to try to improve the response of hypomethylating agents in MDS, because what I showed you is encouraging, but it's still, they're not curative treatments, and they're short-lived responses, right? They're about a year, maybe year and a half, and then the drugs stop working. And so there are a number of doublets being evaluated in clinical trials in combination, in the cases listed on this slide, with azacitidine versus placebo. Sorry, everyone's getting azacitidine, and they're either getting the investigational agent, which is either what's listed here, sabatolimab, which is an immune checkpoint inhibitor, tamibarotene, which is a retinoic acid receptor alpha agonist, magrolimab, which blocks the don't eat me signal on cancer cells, so allows your immune cells to engulf and kill the leukemia stem cell. And then a drug called venetoclax, which inhibits an enzyme called BCL2, which allows the cell to survive the damaging effects of the hypomethylating agents. So by inhibiting BCL2, you're impacting or influencing or increasing the activity of the hypomethylating agent. So these drugs, azacitidine with either placebo or these active drugs, are actively enrolling in clinical trials, large clinical trials, some of them as big as 500 patients. And some of these may be available to you. For example, at Sunnybrook, we're enrolling on the sabatolimab randomized trial, and shortly we will be opening the Verona study, which will be testing venetoclax with or placebo in combination with azacitidine. Next slide. Now, I just want to finish off about bone marrow transplant, and I mentioned that bone marrow transplant is the only curative option for myelodysplastic syndrome. And historically, we always thought the transplanters always would show these survival curves and say, well, look, our outcomes are better if you have a transplant and if you don't. But the problem is that people who go on to a transplant tend to be younger, they tend to be fitter, they're able to undergo the rigors of a bone marrow transplant. And so it wasn't really comparing apples with apples, because the patients who don't go on to transplant, there's a reason for it. They're usually, either older, or they have too much frailty or comorbidity or disability that the transplanter says, no, you're not fit enough. You're not going to be able to withstand the toxicities and risks of a bone marrow transplant. So we finally have better evidence in support of allotransplant, the survival benefit provided by allotransplant, by one of two trials. This is one of them that was presented last year at our international meeting. It was a big cooperative group study called the Bone Marrow Transplant Clinical Trials Network trial. And what they did is what's called a biological randomization. So they basically said, do we want you to have a transplant? Yes, no. And then they would say, okay, if you have a donor, you're in this arm. And if you don't have a donor, you're in this arm. So it's what's called a biologic randomization. So they were basically apples with apples, the difference being one group was able to have a transplant because they had a donor, and one group was unable to have a transplant because they didn't have a donor. And what they showed was, and so 260 had a donor, 124 did not. It still showed a significant improvement in survival and almost what we would perceive as a plateau in the survival curve. Once you hit the 2-year mark, it looks like the disease seems to be cured or is hopefully cured at the 2-year mark, with the survival of 48% in the donor arm at 3 years versus 27% in the no donor arm. So we now have conclusive evidence that transplant should be what we aspire to. However, and certainly with kids now being able to be donors, what we call haploidentical donors, although they were excluded from this study, more and more patients are going to be eligible to have transplants. Next slide. So just to finish up, MDS is a disease of the myeloid blood stem cell that leads to bone marrow failure because of it's the ineffective factory, and a propensity to develop AML in about 1/4 to 1/3 of patients. The life expectancy of someone with MDS is truncated by the disease, whether or not you have whether or not you have leukemia or not, develop it or not. We gear our treatments according to the risk score, as I showed you in our algorithms. Despite that, though, many patients do require transfusions, red blood cell transfusions, and we're trying to reduce the need for transfusions or eliminate them completely with our new therapies. Allotransplant is the only potential cure, although in reality, only about 10, maybe 15% of patients qualify. That may be changing, again, with more donors, but with an average age at diagnosis of 76, you can imagine that in some cases, it's just not an option. We now have an oral hypomethylating agent that's equivalent to the IV formulation and is probably interchangeable with azacitidine, but with some subtle differences, as I outlined in the previous slides. We now have loose pattercept as a new drug that's approved for lower risk patients who have ring sideroblasts, who are transfusion dependent, and will either reduce or eliminate transfusions in about half of the patients. And patients are going to be able to receive them if they've either not been a candidate for ESAs, erythropoietin, EPRAX or darbepoetin, or if they received the drugs, the ESAs, and didn't respond or lost their response. And there are numerous clinical trials underway. I only highlighted a few of them. This is there's a website called clinicaltrials.gov where you can search on the trials that you want and you can narrow your focus. And basically, when I just typed in myelodysplastic syndrome, you can see that there are 168 phase 1 trials. So, testing, finding, correct and safe doses of new agents. There are 209 phase 2 trials looking for activity, and there are 38 randomized controlled trials going on. So late stage drug development going on. So a lot of promise in this disease. Next slide. And AMAC is a wonderful website and to provide you more information. And I'm also providing you and AMAC is strongly affiliated with the international organization called the MDS Foundation that has excellent resources. There's a beautiful animated guide to myelodysplastic syndrome that I would highly recommend. And then there's this, what we call Building Blocks of Hope, which is basically kind of a layperson's encyclopedia about MDS and talks even way more about of things than I've actually wasn't able to cover in the last hour. And finally, this thing called MDS Hub, which is an international effort to try to unify treatment policies and provide evidence for clinicians as well as patients who have this disease or treat this disease. So I thank you for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Buckstein. Does anybody have any questions? I don't see any in the chat box or the question box just yet, but I'll just give you a moment if you want to type your questions in. I agree about the building blocks of hope. It's, I think, probably our most popular request for guides. Our patients absolutely rely on that guide and love it. It's a bit of a Bible. When we have new patients join support groups, it's always one of the most recommended resources to have, for sure. This would be your opportunity to ask any questions. Also, you could also, I can unmute you if you'd prefer, and you can ask your question directly to Dr. Buckstein as well. We have a large group today, but they seem to be quiet. Well, I don't see any questions coming in, so maybe we'll just leave it at that. I thank you so much, Dr. Buckstein, for your time tonight. I really appreciate it. I apologize for the technical difficulties. Thank you everyone so much for tuning in. And again, this is recorded. Oh, caught me just as I was, just saying thank you so much, Rena. Excellent talk and very well balanced. I agree. Coming from Dr. Khalaf.
Thank you, Dina. Next time it'll be you.
Yes, yes. I had the pleasure a couple of years ago in Hamilton with Dr. Khalaf, so it'll be her turn next. She's smiling. Great. Well, we'll end the call for now. Again, thank you so much, Dr. Buckstein, and everyone have a great evening, and we'll speak soon. Bye, everyone.
Bye.